This talk illustrates how to use this Center for Evidence-Based Medicine worksheet for prognosis studies when performing a critique. Let's start with a clinical case scenario. So a 23-year-old athlete just experienced a non-contact ACL rupture 4 weeks ago. They have no pain, swelling, their range of motion is normal, but they have a 50% strength deficit. They want to return to high-level competitive soccer. And you're wondering precisely what criteria you're going to use for return to play. The return to play criteria that the patient might be worried about is just whether they're going to re-hurt themselves or re-injure themselves or not. But the therapist who has to make the decision has to base it on something. And so should strength be used? Should performance-based criteria be used? Is something like the HOP test the most effective? What criteria would best assure safe return to play or return to play without injury? The two different perspectives on the same question. So we'll search, and I found a higher level retrospective cohort study to critique that evaluates the chance of re-injury after ACLR and rehab, so ACL reconstruction and rehab. It's focused on biomechanical measures during landing and postural stability, predicting second anterior cruciate ligament injury after anterior cruciate ligament reconstruction and return to sport. It's published in 2010. So the interesting thing about this study is the factors are all neuromuscular related, and it has to do with the neuromuscular hypothesis, as that's the thing that makes athletes most at risk because the injuries are non-contact. So the focus of the variables to make the prediction, and in other words, the tests and measures that should be used at the return to play point, in this particular study had to do with landing and postural stability. So the variables, some of them could be obtained with 2D visual analysis, others required a motion analysis lab. And then they also had something relatively simple you could collect in terms of postural stability that's available in most sports medicine clinics. And the idea was they were going to look at specific criteria that was established for these different tests at return to a sport clearance by the physician and the therapist, and then wait for 12 months, monitor their outcome relative to injury, and then look at which of these variables collected, neuromuscular factors collected at return to sport, predicted injury within 12 months. So the critical appraisal starts with the first question: is are the results valid, or what is the validity of the study itself? And so the defined questions from the worksheet start with, was a defined representative sample of patients assembled at a common point in the course of their disease? So taking this one phrase at a time, so the sample is defined, meaning that there were diagnostic or staging criteria that were used to kind of define the participants. And was the sample representative, meaning that they had a full spectrum of the illness. So in this case, they would have things like meniscus injuries or other ligament injuries that are commonly associated with ACL reconstruction, and further that they weren't primarily, there were a variety of different kinds of athletes, so they weren't one like soccer players or something like that. They had a broader spectrum of participation in sports. And then the third phrase here is common point. So this is focusing on timing, and typically this is the inception point or start of the disease. So in this case, that would be better defined as preoperatively. However, it's also acceptable and good to use another common point in the disease as long as it's very concrete. And so the return to play point is a very concrete transition in the disease process when somebody goes from rehabilitation to their previous activity. And so it's an acceptable common point in this particular case. So we can apply that to this study design. We recognize that the sample was drawn from an existing database, so there are 56 young competitive athletes who were all returning to pivoting sports following their ACL reconstruction. So it doesn't meet the definition of the sample. It's very defined, but it doesn't cover much of a spectrum. So that's essentially why it's a level 2 study, because of the lack of a representative sample. The inception point is very well defined. It's at the return to sport evaluation, so that's acceptable. And the follow-up or attrition for these people is pretty low. And then we have a total of 13 people suffering the injury. So it mostly meets this criteria, but it's not as good a representative sample as we would like. So the second question is, was the patient follow-up sufficiently long and complete? And essentially here what we're concerned with is is it sufficient length of follow-up for the outcome to occur, either one way or the other, good or bad. And so we can look at examples like some extreme examples would be if we think something is predictive of knee OA, we might have to wait too long to see that outcome. Like a 1-year study would miss the outcome. The arthritis wouldn't have had time to develop. And so the length of time for the outcome to occur for OA would have to be fairly long for it to be compelling that whatever variable we're looking at actually prevented OA or facilitated OA. In terms of return to play, we could look as soon as 6 months or up to 2 years, whatever is reasonable. For low back pain, we expect plateauing in recovery to occur around 8 to 12 weeks, and so a 3-month time point to look at a return to work for acute low back pain would be adequate. For ankle sprains, we expect recovery in the 4-week range, and so again, a lower time point for documenting return to play would be adequate. And so essentially you can see that for each of these different diseases, there's a different length of time of follow-up. And we want to optimize the length of time. We don't want to go too long because then we'll start to have attrition problems or problems tracking people. At the same time, if we go too short, we'll declare the success of the treatment or failure of the treatment because we didn't allow for enough time for the outcome to have occurred. So there's a trade-off between allowing a sufficient amount of time and experiencing attrition issues as you make the decision of follow-up. So in this particular case, the patients were followed for 12 months post-testing. This essentially documents a 1-year prevalence of re-injury. Other studies have done 2 and 5 years, so this is on the lower side. However, it's the minimum, I think, for re-injury rates. Longer follow-up may also be influenced by other variables. So this has the advantage of tightly linking the variables to the result after a rehabilitation. So I would answer here yes, with the limitation that longer-term follow-up rates may be different. Were the outcome criteria either objective or applied in a blind fashion? So here, this is striking at the idea of are the outcome variables reliable and valid? And different ways of defining this are interesting. So basically, you can document how many people have a clinically meaningful change on an outcome measure, and that works fairly well. Or you can use something like a dichotomous outcome, like in this case, a return to work, return to play, death, stopped using an assistive device. These are fairly concrete and significant clinically. Or you can use physiologic or clinical outcomes like a significant range of motion change. For example, in shoulder, external rotation range of motion greater than what's necessary for upper extremity elevation or greater than 90 degrees may be a significant transition point for somebody with shoulder problems. Isokinetic dynamometer test or other survey instruments. And then the importance of blinding has to do with both at the point of establishing the prognostic factor and at establishing the success or presence or absence of the outcome. So both of those points are important for blinding. So in our example, the injury rate was the outcome. An injury rate was defined as re-injury divided by exposure. Re-injury was defined as rupture verified by arthroscopy, MRI, or change in the CompuKT knee laxity test. All of these are well-established tests that have known accuracy, which is fairly good. And then exposures, they called patients every month or so and asked them if they had had an injury or not until the follow-up period was complete. So this is a fairly acceptable way to document exposure. So these are both fairly objective ways to both document re-injury and exposure. So on the objectivity question, we answered yes, but there's no blinding mentioned anywhere in the paper, and so on that it was a no. The next question has to do with subgroups. If subgroups with different prognoses are identified, was there adjustment for important prognostic factors? And this gets at the idea that different prognostic factors can modulate others in important ways. And so understanding how the prognostic factors are interacting can be relatively important in a disease process. ACL is a good example. In ACL ruptures, there's commonly bone and meniscal injuries, and there's a gender bias toward females. So how all three of those factors modify the ability of neuromuscular problems to predict disease would be important if we were going to effectively use this criteria for estimating injury rates in our patients. And so stratification can be one way to approach this, where you subgroup older and younger people, or males and females, and make comparisons across them. That's one approach to satisfying this criteria. Other approach is entering variables into either a logistic regression model or a multiple linear regression model, and looking at the influence of those variables on the predictions. And then sometimes, though, there is problems with subgroup analysis because things like gender predict meniscus problems, and they may or may not make sense. And so there is this issue of biologic plausibility, but most of the time that's fairly straightforward, and we have expectations related to like age and younger patients getting better faster than older. In this case, female patients being injured more often than males. So in our particular example, there was no subgroup analysis performed, and therefore the potential important modifiers of age, gender, concurrent injuries like meniscal damage were not taken into account, and how those modifiers may have retarded or changed the estimates in the study are not being considered. Now, this is primarily because that it is a retrospective cohort design, and the sample was highly specified by choice because it was extracted from an existing database. And as an example, there weren't sufficient older individuals in this particular study to assess the effects of age. There weren't a sufficient number of males to assess the effects of gender. And meniscal damage was ruled out as a inclusion criteria. So basically, it wasn't taken into account. So this is a typical problem with retrospective cohort designs, and one of the reasons why they're considered a level 2 instead of a level 1 type of study. So in summary, the strengths of the study are the representative sample or a common point, and it's true, there's an inception point that's very good, return to play. It's a retrospective cohort, and so the spectrum is not quite adequate for us in terms of applying it practically in the clinic, but there was extremely low attrition. So on this rate, we have fairly good confidence in the sample, with the exception that some variations in the disease aren't taken into account. There was very low follow-up. It was objective, but there was no blinding, but there was no subgroup analysis. So we can see the pluses and minuses here. And so why a level 2B? It's been fairly well represented here. The diversity represented in the disease is not fully expressed. And so things like the effect of gender, other comorbidities, type of surgery are not taken into account. So level 1 studies require diverse samples so that we can effectively apply the results to patients with confidence that they take into account these subtle other factors that are also potentially modifying the prognostic prediction. Okay, so essentially we've answered the question of if it's valid. It's a high-level study with some reservations. Now we want to ask the question is, what are the results, and are they clinically important? So essentially here we're really asking the question, how confident are we that the results will actually occur over time, and then how precise? So two essential questions. We're going to use for prognosis the idea of prediction. So the idea of prediction is captured in regression analysis or correlation types of things, and where we can get an R value or R square values. We can also get a standard error of the estimate from that. Then we get odds ratios or relative risk ratios. Now we can change the question. Instead of just asking if it's correlated, we could say, can we make a dichotomous predictive outcome? And then in that case, we can measure accuracy. And if we do that, we're going to see something like our receiver operator curves, sensitivity specificity, or something like a Kaplan-Meier survival curve. Most of the time, we see odds ratios quite a bit, and we also see the accuracy assessment often. So odds ratios and relative risk ratios are proportional estimates of risk, and so we'll go through a specific example of both of these in a minute, and you can familiarize yourselves with the definitions offline. So in terms of interpreting odds ratios and relative risk ratios, they're interpreted the same, where a relative or odds ratio of equal to 1 suggests there's no effect of the prognostic factor. An odds ratio greater than 1 or relative risk ratio greater than 1 suggests that there's an increased likelihood of the effect, and less than 1 suggests that there's a decreased likelihood of the effect. So let's give an example here. This is a Kaplan-Meier plot, and in a Kaplan-Meier plot, what you start with is at the beginning of the disease process or your documentation, and then you follow it over time for the event that you're interested in. So in this case, we're looking at hip fractures, and at the point of the hip fracture, it's common for approximately half patients to have delirium. And this scale, the short mini mental status questionnaire, is a way of documenting delirium. And so the patients on the top line here passed and qualifies not having delirium, and the patients in this bottom line have delirium. And what we're counting here is mortality at 2, 4, up to 16 months. And so we can see over time that the patients with delirium, a higher percentage of them experience mortality relative to the patients without delirium. And so at the beginning of the test, there's everyone's alive, and then as time progresses, some patients experience mortality, and in this case, the ones with delirium more so than the ones without. So let's look at the 1-year outcomes and calculate a rough odds ratio. So the odds ratio essentially looks at how many patients are surviving in the group with delirium, and compares that to the number of patients surviving without delirium. And what you're going to look at is a relative rate. So we have here essentially survival at 1 year. For the group that's above 3 is 85%, survival at 1 year, and the group below 3 is 60%. So we want to know the risk of death for the relative to the group that's surviving. So we basically calculate the number of people who are alive, who died in the high delirium or the delirium group. So it's around 40%, and then we divide that by the number of people who died in the non-delirious group, and we can see that gives us an odds ratio of about 2.7 times more likely to experience death at 12 months if you don't have if you have delirium. So essentially, this projects like a high negative outcome for people with delirium, but so in terms of an odds ratio, this is significant. It's an important factor to consider in patients when they present after hip fracture. But let's change the question a little bit. So odds ratios help us understand that the rate's quite a bit higher in one categorical group than another, which is useful to us clinically. But it also doesn't answer the question of accuracy. If we were using this value of greater than 3 or less than 3 to judge who would be alive at 12 months, would we accurately predict the number of people with delirium that wouldn't be alive? And the answer would be no. 60% of the people would be alive, 40% would not. And so we would have guessed incorrectly on around 40% of the people with delirium. And so it brings up the point of correlations versus our probability values and accuracy estimates. It's always better to use accuracy estimates in your clinical decision making than it is to use odds ratios. So here's a good example. So in this the study that we were looking at, they looked at a variety of neuromuscular factors that predict injury, a second injury after a return to play. The factors are listed here. We note 1, 2, 3, there's 4 listed factors, and we can see that hip rotation in net impulse had an odds ratio of 8.4 times. It was the highest, but we also notice that postural stability on the involved limb was also quite, had an odds ratio of 2.3 times more likely to re-injure than if you had good postural stability. So essentially we can look, let's keep this in mind as we go through now and look at the accuracy estimates of these various variables. What we're going to notice is that there's some accuracy given to these top 3. Not much is going to be assigned to postural stability, and then the estimated accuracy is fair with some errors, and we'll notice that. And so what I would encourage you to do is take odds ratios with a grain of salt, because although they indicate a relative importance of a factor, they don't give you the absolute importance of a factor relative to accuracy. And clinically, that's what you need to make decisions with patients. So the other approaches are multiple linear regression and logistic regression. We favor logistic regression because we can use receiver operator curves and sensitivity specificity analysis, which closely mirrors our clinical decision making. And we're not covering today our square values. So in this particular study that we've been talking about, there were several neuromuscular factors that were considered. And the success of these factors is quite high. In fact, a combination of 4 factors listed here, all related to the landing mechanics during a drop jump, were found to be significant and accurately predict re-injury. But when the analysis was run, postural stability was excluded. So even though it had a positive odds ratio, it was actually not additive in terms of helping the accuracy of the estimate of the other 4 factors. So we can see here's their receiver operator curve. We notice that the line of no effect is here, and it approaches 1, so we can tell that it has a significant improvement in using these factors over not using them in terms of estimating who will and won't get hurt. The sensitivity and specificity values for using all 4 factors is quite high, around 0.9 for both, meaning that there were relatively few false negatives and false positives given if you were able to use all of these factors. So the factors included measure the amount of knee abduction that occurred in a 2D projection on landing, an imbalance on the uninvolved versus involved side, where you can see this is the projection of the ground reaction force in front of the knee on the uninvolved side, so that would have a flexor internal moment, and this would be the projection of the ground reaction force behind the knee. So meaning there was a very asymmetrical landing from one knee to the other in the sagittal plane. in the landing mechanics. And then here there was an excessive internal rotation hip moment on landing on the uninvolved side. So basically these 4 factors were significant in predicting who would get injured, and resulted in the sensitivities and specificities around 0.9 that I just showed you. So those are fairly impressive, but then we ask a second question of how precise was the prognostic estimate. And what we can use to kind of look at this is what are the confidence intervals if they're given to us, and then we can also look at the sensitivity and specificity values and ask questions about the number of false negatives and false positives that would result were we to use those estimates. So we can start again with the odds ratios table, and we can focus now, instead of on the point estimate that was given here, the actual confidence interval and the odds ratios. And we can see the highest single variables, the hip rotation moment variable of the uninvolved side, which is quite high actually. But look at the confidence interval. It ranges from 2.1, which would be fairly low, and as high as 33.3, which would be very significant. So the range of possibilities for this variable are quite high, from almost clinically insignificant to extremely important, especially when we consider that odds ratios at 2 or less are considered very low, and ones that are higher than 10 are considered very significant. Now, the reason for this is that the overall number of injured athletes is low, with only 13 of 56 people being injured. So then we can take a second look at this data and ask the question, well, what is the false negative, false positive rate really like? And here they're taking a single variable, the hip moment data, and noting this is the external rotation component here, and then it goes into internal rotation. So an example of a person who wouldn't show this effect is the red. Okay, and so basically this person's at higher risk. And so if we look over here, this is the impulse data, so it's the area under this curve here. And we can see that the red values here are the number of people who are injured, and then on the x-axis is the actual impulse data from each participant. And so when the impulse data was above around a 2, okay, what they determined was that person was at higher risk for a second injury. So let's count the number of false negatives and false positives that would have occurred. So let's start with the false positives. So if we used a 2.4 here, or around a 2 here, what we would discover is that 1, 2, 3, 4, 5, 6, 7, 8, 9 people would be truly identified, and there'd be 1, 2, 3, 4, 5 people would be falsely identified as at risk when they didn't actually experience an injury. And then if we look here for the people who passed the test, they were low, so they had an adequate, a more normal amount of rotation moment. We can see 4 of those people that we cleared actually hurt themselves, and then 38 were accurately predicted. So in essence, if we were to use this data, 5 of the people we told that they were at risk of injury really were not. 9 people were accurately predicted, and we might have been able to protect them by extending their care. And then 4 people we would have said that they were really safe, but they would have actually hurt themselves. So essentially, this is pretty acceptable given the difficulty of estimating these problems. But the second question would have to do with, can we remediate this motor control pattern? So, a summary of results. The neuromuscular factors were successful in classifying individuals at risk for injury at return to play, especially based on the receiver-operator curve, sensitivity, specificity, and odds ratios. However, the precision of the estimate was low and resulted in some level of false negatives and false positives. So essentially, we've done the validity examination. We've also completed interpretation of results, and now armed with that, we can ask the question of how exactly we would apply these data to our patients. So the first important note would be that to apply them to our patients successfully, they can't really have had meniscal injuries, and they should be high-level young athletes. The same predictions may not work as well in other groups of people with meniscus injuries or less competitive athletes. Now, the testing feasibility is a major issue that would require training, cost, and an imposition to the patient for sure. So this practical part may prevent us from implementing it, but those are things you should definitely consider when you are matched up with this question. And finally, the value to the patient or payer or therapist. Does the patient really value the result of the test? Do they want to know the likelihood of re-injury or not, or is it best for them not to know given the situation? And so in our case, it really does help for goal setting. It definitely emphasizes the fact that neuromuscular factors can be really powerful prognostic factors and we should use them as goals for therapy for things like symmetrical landing patterns, frontal plane control, preventing that two-dimensional knee abduction angle, and we should focus on rotation control at the hip at discharge for return to play in our patients. Whether or not we can use the precise data from that clinical trial would be whether or not we had access to a motion analysis lab and somebody that was capable of obtaining these exact values. The patients that fail to meet these goals, you would really need to seek out further evaluation and look into other tests to evaluate their status. So essentially, the ones that fail to meet these goals, the approach to remediating them as yet is not fully verified. So that would be up to you to kind of invent that or come up with some plan to deal with that before implementing these rules. So some parting comments: you should expect a very complex analyses. Most of the discussion has to do with logistic regression and prediction analysis, which are fairly complex. Long-term follow-up, remember that the longer it is, the higher attrition and different variables influence some of the things we're trying to tease out in terms of the research process. And that concludes this